Hi everyone, welcome to Imaging Study. Today we are going to see a case of hemorrhagic ovarian cyst. A 28 years old married female patient was sent to us with a history of right lower abdominal pain. Let's see what we have got on ultrasound. Here I am starting with the trans-abdominal ultrasound. You can see on the right adnexa there is a well-defined cystic structure adherent to the right ovary here. And on color Doppler there is no internal vascularity. But you can see something within this cystic lesion. To evaluate more, we did a transvaginal ultrasound. Here you can see the cystic lesion and you can see internal solid-like area with some reticulation. Again the cystic lesion, you can see some follicles adjacent to the cystic area. So possibly this lesion is originated from the right ovary. On color Doppler, there is no vascularity within this solid component, which goes in favor of retractile clot of hemorrhagic cyst. Now let's jump into the transvaginal ultrasound. Here you can see the longitudinal section of the uterus. It looks quite normal on transvaginal scan. You can see the mass-like area adjacent to the fundal region, which we'll discuss a little bit later. Here's the transverse section and you can see on the left adnexa, the left ovary looks quite normal. There are tiny follicles within. When we magnified the image to evaluate more about the left ovary, it shows no definite abnormality. Now let's look at the right adnexa. Here's the right ovary. You can see the lesion is originated from the right ovary here. And it is a well-defined thin-walled cystic area having internal lace-like reticular pattern. This reticular pattern goes in favor of hemorrhagic cyst. You can see some solid-like area here which appears to be the retracting clot. This concave margin is a feature of retractile clot. You can also see the posterior acoustic enhancement as it is a cystic lesion. To evaluate more about this solid-like area which we are telling about the clot, you can go for color Doppler ultrasound to check internal vascularity. Now again another feature, if you check carefully you can see some sediments are going backwards to the dependent part, which also goes in favor of blood products. Here is the picture of the right ovary. You can see multiple follicles and at this part you can see the cystic lesion that we have seen previously is connected. Again the part of ovary and the part of cystic lesion with retractile clot having concave margins and some lace-like reticulation. The maximum diameter measures around 5.6 cm. It is important to note the maximum diameter, which I will talk a little bit later. Here on color Doppler you can see there is no internal vascularity. This solid-like area is devoid of vascularity indicating clot and blood products. You can see normal flow peripheral to the cystic lesion. This normal flow is the flow of normal ovarian parenchyma. So this features conclude it as a case of intraovarian hemorrhagic cyst. Here's the color Doppler picture and you can see there is no internal vascularity. As like other lesions, we have checked the spectral Doppler here. The most nearby artery shows moderate resistant wave pattern. The resistive index is around 0.5 and this wave pattern without presence of early diastolic notch indicates that this vessel is possibly originated from the ovarian artery. So in summary, a well-defined thin-walled cystic area of more than 5 cm in maximum diameter having internal lace-like reticular pattern and retracting clot demonstrating concave margins with posterior acoustic enhancement is noted within the right ovary. This features goes in favor of hemorrhagic cyst, and the O-RADS score will be 2, which suggests the lesion is almost certainly benign. Color Doppler shows the absence of flow within the internal blood products. So according to IOTA group, the color score is 1. There is normal flow seen in surrounding ovarian tissue. The most adjacent vessel of ovarian arterial origin shows moderate impedance flow. Now the take-home message. Using the O-RADS and IOTA descriptors and classification system may help clinicians understand the lesion characteristics and manage the patient accordingly. This patient with more than 5 cm maximum diameter lesion should get a follow-up scan in 8 to 12 weeks. If it persists or enlarges, then the gynecologist will concern about the lesion and may do MR imaging for further evaluation. Thank you for watching this video. Subscribe to our YouTube channel for more. See you on the next one. Have a nice day.